Hey, this is Dr. Nick, and we're going to continue this third lesson in the section on QRS axis. Now we're going to deal with axis deviation. And I've put the shopping list of causes of left axis deviation. You can have left and you can have right axis deviation. Well, what does that amount to? Well, think of the heart again, and you have fairly thin right ventricular free wall. You have your septum, which is pretty thick, and your left ventricle, which is thick as well. Of course, your atria are up here someplace. So what normally happens is the electrical vector winds up going down and to the left. But now there are a number of different things that can shift this axis upwards, and that would give you a left axis deviation. Anything that causes this part of the ventricle to enlarge and become heavier, or anything that shifts the sequence of activation of the left ventricle around, disturbing the normal sequence of activation can result in shifting of the axis upwards and towards the left. We'll talk specifically about how this happens in our discussion of hemiblocks later on in the intermediate course. But for now, let's just discuss the more common causes of left axis deviation. It can occur as a normal variation, and usually what we're talking about is an axis, in the range of minus 20. More of a leftward axis is usually normal, but it could possibly reach minus 30 as a normal variation. Left ventricular hypertrophy is a very common cause of left axis deviation because you have all of this left ventricular free wall activity, and it winds up causing the electrical vector to shift towards the left ventricle, which basically this disturbs the normal relationship between the right ventricle, which is thin, and the left ventricle, which is thicker. A left bundle branch block is another common cause of left axis deviation, although not always. Anterior fascicular blocks will be discussed in detail later in this intermediate course. Now, just a word about inferior myocardial infarction. Remember, the inferior wall is the underside of the heart, and if you wind up with an infarction in that part of the heart, then there's a relative absence of electrical signals that are headed towards the bottom part, and so the net electrical vector winds up shifting upwards and towards the left. So left axis deviation is commonly seen in inferior myocardial infarctions, and when we discuss how to diagnose myocardial infarctions later in this intermediate course, we'll relate that axis deviation to it as well. Usually in lead 2, you'd expect to see a fairly healthy R wave, but in an inferior wall MI, those forces headed towards lead 2 are conspicuously absent, and in fact you wind up with Q wave and a shift in the axis with most of the electrical signal being below the baseline. And that tells you that the electrical signal is headed away from lead 2 up in this direction. Congenital heart disease can disturb the normal architecture of the left ventricle, and other less common causes of left axis deviation include emphysema, hyperkalemia, and preexcitation, otherwise known as the WPW syndrome. We touched on this briefly in the basic course, but the advanced course will cover this in much more detail. Of course, if the diaphragm is pushed upwards for some reason, like by a large uterus or fluid in the abdominal cavity, such as you'll get with ascites, or if there's a big tumor in the abdomen that pushes the diaphragm up, well, that will physically shift the heart to lie more horizontally and then winds up with your axis shifting leftward. So that's more of just a mechanical shift rather than it being an electrical or a structural shift. Okay, what about right axis deviation? Well, sometimes hearts can be relatively vertical in the chest, and that can wind up shifting the axis a little bit sort of rightward. So normal variation is one cause of a rightward axis. Mechanical shifts as well. If the right ventricle becomes thickened for a variety of reasons, then you have more electrical signal being generated by the right side of the heart, and the electrical vector will shift towards the right. Right bundle branch block and posterior hemiblock are electrical disturbances that can cause a shift in the axis. Dextrocardia is a condition when you're born with the heart on the right side of your chest. It's a congenital abnormality, and because the heart is now lying this way, the axis, of course, is going to be very bizarre, as will the rest of your ECG. Preexcitation syndrome, or WPW, can cause marked shift in axis. Just like an inferior wall myocardial infarction can shift the axis leftward, if you have a lateral infarction where this part of your heart is damaged, then the electrical vector shifts from this direction to this direction. So you get a right axis deviation with a lateral wall MI. Anything that causes right ventricular enlargement, either acutely or chronically, can shift the axis to the right. So pulmonary embolism causes acute increased right ventricular size and wall tension, and a chronic condition that occurs in patients with lung disease is known as cor pulmonale, and that causes right ventricular enlargement and hypertrophy, often seen with pulmonary hypertension. Okay, well, let's start getting some practice here. We'll concentrate on the frontal leads again, and the first thing you should do is look for the one frontal lead that seems to be most isoelectric. This seems to be more positive. This seems to be more negative. This is positive. This is pretty close to being isoelectric. It's certainly the smallest lead, but if you carefully examine the baseline, you see that most of the QRS complex is below the baseline, about 2 millimeters below, and there's only about 1/2 millimeter above it. So this is clearly more negative, although not by much. Lead 2, on the other hand, shows about 3 millimeters above and below. So even though lead 2 is larger than AVF, it seems to be most isoelectric. Now, where is lead 2? Lead 2 is going down 60 degrees from the horizontal. And if lead 2 is most isoelectric, that means the electrical signal is traveling perpendicular to that, which would make it minus 30 degrees, bordering on left axis deviation. And generally what I look for is if all 3 inferior leads are negative, then I call left axis deviation. Notice, however, that AVR is still negative. Where is AVR located? Well, AVR is 30 degrees above the horizontal going in this other direction. And for the most part, the QRS complex should always be negative in AVR unless the axis is minus 60 degrees or better. If you see a positive QRS complex in AVR, then you're clearly dealing with axis deviation. I'll show you a few more examples of this. AVR is obviously very positive here, and 2, 3, and AVF are markedly negative. Lead 1 is the only lead that seems to be fairly normal. So where do we put this axis? So here's lead 1, and since this is positive, we know that it's got to be in this half of the circle. It turns out that lead 1 is probably the most isoelectric. All the other leads are very large. And even though it's more positive than negative, we have to call this axis very close to being minus 90. Now, it's not exactly minus 90, but there's no other lead that's as isoelectric as lead 1. If AVR was isoelectric, it would be minus 60. And so it's clearly more than minus 75 if you wanted to be precise. And if you did it the mathematical way, I think you'd find it to be probably minus 80 or 85 degrees. I think this would be the closest guesstimate given the configuration of the QRS complex here. What would make an axis deviation that abnormal? Well, this is an example of left anterior fascicular block or left anterior hemiblock, which is characterized by having a little R and a deep S in lead 3 and a small Q with a taller R in lead 1, as well as an axis of minus 60 degrees or better. But we'll talk about anterior hemiblocks and why it looks this way later in this course. Just I want you to get comfortable with determining the QRS axis. In this case, it's about minus 80 degrees. All right, here's another example. It's a little bit easier. AVR is clearly negative, so it's not going to be quite as bizarre. But you see lead 1 is positive, but AVF is negative, so it's not in the normal quadrant. As 2, 3, and AVF are negative, that places it in the top half of the circle, and lead 1 being positive puts it into this quadrant. Well, which lead is most isoelectric? It looks to be lead 2. That has about 10 millimeters below and maybe 6 above, which is more isoelectric than AVR. It's not perfect, though. So for the ECG experts in the crowd, lead 2 is 60 degrees above the horizontal, and if it were isoelectric, that would give us an axis of minus 30, but it's a little more negative than that. And remember, I told you if 2, 3, and AVF are all negative, then you're clearly dealing with a left axis deviation. But AVR is not as isoelectric as lead 2, so it's not as far as minus 45, and I'd call it minus 40, and I think if you read it on the computer printout, that's about what the computer would calculate mathematically. Now, why does this patient have a left axis deviation? Well, look at the size of the R wave in lead AVL. If you measure it, it's almost 20 millimeters. And if the R wave in AVL is greater than 11 millimeters, well, that's one of the criteria to diagnose left ventricular hypertrophy. You have several other criteria here that you meet. Huge S waves in 2 plus a big R wave in 1. That's one criteria. And then in the precordial leads, you also have voltage criteria as well as ST segment abnormalities consistent with LVH. So that's why you have a left axis deviation of minus 40 degrees. In this tracing, it's because of left ventricular hypertrophy. Okay, last one just for practice. Now here, if we kind of look at 1 in AVF, we see AVF is positive, but lead 1 looks to be negative. Well, that would place our axis on this side of the circle, wouldn't it? Because we're going away from lead 1. Lead 2 seems to be most isoelectric. Remember that lead 2 is going in this direction, 60 degrees above the horizontal. So the axis in this tracing looks to be over here, a marked right axis deviation. It's 90 plus another 60. That gives us plus 150 degrees. Now here again, AVR is positive, and that tells us that we're here, the abnormal side of the circle, because what you have here is left posterior fascicular block or left posterior hemiblock in combination with a right bundle branch block with notching in V1 and V2 and a wide deep S wave in the lateral leads here. So you've got right bundle branch block, left posterior hemiblock, giving you this marked right axis deviation of plus 150 degrees. As we work our way through all these ECGs in the intermediate course, I'm going to keep pounding home these points about determining axis and using axis deviation to help you make diagnoses. In the last video of this section, I'm going to touch on the precordial leads and how precordial lead progression can become abnormal and it can help us make diagnoses as well. I'll also introduce the idea of anatomical correlates to different ECG leads so we can nail down the anatomical regions that we refer to, such as the lateral leads and the anteroseptal leads and the inferior leads as we go on and start talking about ST segment abnormalities and other regional myocardial problems. So for the ECG Academy, this is Dr. Nick. Thanks for watching.